Thank you, dear Professor, Mr. Chairman. I will talk about lactate and the kidney from bedside to bedside. I will talk about the most two common types of lactic acidosis, L type and D type, starting by the most common of them, Lactic acidosis, starting by pathogenesis and causes. At first, I will go back to the basic physiology of lactate metabolism. If we suppose that this is the systole or cytoplasm of any cell, and this is the mitochondria of any cell containing mitochondria as muscles, normally lactose is converted to pyruvate by a series of enzymes, converting NAD into NADPH and to form ATP. Pyruvate has two pathways, either to be converted into a lactate in an aerobic situation with no need of oxygen, and this reaction is reversible, converting NAD into NADH and to the opposite side. The other possibility for pyruvate metabolism is to be uptaken by the mitochondria and converted into acetyl-CoA in aerobic condition in the need of oxygen by the pyruvate dehydrogenase enzyme, and the acetyl-CoA enters the Krebs cycle or citric acid cycle. One of the important components of the normal citric acid cycle is the oxaloacetate. Pyruvate can be converted directly into oxaloacetate in the presence of oxygen by the pyruvate carboxylase enzyme. Citric acid cycle will form ATP and NADH and FADH. The ATP formed within the cytoplasm and the mitochondria will be used by the cell to form ADP, phosphate, energy, and the hydrogen. The hydrogen formed normally by the usage of ATP in the presence of oxygen with the NADH and FADH formed by the citric acid cycle will be used by the electron transport chain and oxidative phosphorylation in the mitochondria to reform ATP. The normal metabolism is lactate. It will be increased in the cytoplasm and move to systemic circulation. Lactate will bind the hydrogen in the systemic circulation to form lactic acid. In the circulation, normally lactate will be taken up by the liver. Then in the liver it will be converted into pyruvate, then to glucose, and to be reused by the cells, and this is what is called the Curie cycle. The liver is responsible for metabolism of about 60% of the serum lactate level. The lactate may be also metabolized by the kidney at a lesser extent than liver. If we suppose this is the medulla and the cortex, lactate is taken up by the cortex. In the kidney, multiple possibilities for L-lactate. The first is that most of the lactate will be reabsorbed again. Part of the lactate will be excreted in the urine, about 2%. Part of the lactate will be converted into pyruvate, then to glucose, and back to the cell in the Curie cycle. Within the kidney itself, there is a cycle of lactate glucose between medulla and the cortex. The glucose formed by a cortex will be used by the medulla, which will form lactate, and so on. The kidney normally is responsible for metabolism of about 25 to 30% of lactate. Regarding the normal level of lactate level and abnormalities, normally the lactate level should be between 0.5 to 1.5 millimole per liter in absence of acid-base disturbance. Hyperlactemia is mild to moderate elevation of lactate level between 2 and 4. Lactic acidosis, lactate level will be more than 5 in the presence of metabolic acidosis. So what are the causes of lactic acidosis? We have two types of lactic acidosis, type A and type B, according to the main core of the pathophysiology. Type A is mainly occurred with the evidence of inadequate oxygen delivery, whatever due to inadequate perfusion or hypoxia. Type B causes of lactic acidosis occur with no evidence of inadequate oxygen delivery to the tissue. Starting by type A, all causes of hypoxia or inadequate oxygen delivery as acute hypoxia, anemia, shock, or seizures. The pathophysiology or the mechanism depends on, in the presence of inadequate oxygen delivery in type A, there is no uptake of pyruvate by mitochondria. There is no aerobic uptake or metabolism or pyruvate. So most of the pyruvate will be converted into lactate and it will cause high lactate level in the blood. Also, as we mentioned here, hydrogen is uptaken always by the electron transport chain. So in absence of oxygen, no uptake of hydrogen that it was formed by the usage of ATP. Elevation of hydrogen in the cytoplasm, it will move into the systemic circulation and it will cause high hydrogen level, and the combination of high lactate level and the high hydrogen level in the blood will cause lactic acidosis. Lactic acidosis, in its pathophysiology, it will block the uptake of the liver for L-lactate, causing more lactic acidosis, but actually it increases or stimulates the kidney uptake for L-lactate if the kidney is not diseased, or it is normal, or it is not involved in the pathogenesis of lactic acidosis. And the kidney in this situation compensate about 50% of the disability of the liver to metabolite L-lactate. Regarding type B lactic acidosis, there is no evidence of hypoxia or inadequate oxygen delivery. We have three types of type B lactic acidosis: B1 in the presence of systemic acidosis, B2 drugs and toxins, B3 inborn errors of metabolism. Systemic diseases that cause lactic acidosis in absence of oxygen, inadequate oxygen delivery: liver failure, malignancy, diabetes, pheochromocytoma, and thiamine deficiency. In malignancy, mainly there is lactic acidosis due to increased glycolytic activity in the malignant cells itself, or if there is liver metastasis, which will affect the hepatic efficiency to uptake lactate and metabolize it. Regarding other systemic diseases, how they may cause lactic acidosis, mainly by if there is liver failure, there will be decrease in lactate uptake and metabolism. Thiamine is important as a stimulator for pyruvate dehydrogenase enzyme, so in thiamine deficiency, this enzyme will be inactive. Also, there is an evidence in cases of diabetes mellitus that there is inhibition of pyruvate dehydrogenase enzyme. In cases of pheochromocytoma, there is high levels of adrenaline and noradrenaline, which will increase conversion of glycogen to glucose, so high pyruvate level and L-lactate, and also they have noradrenaline and adrenaline lipolytic activity, the increased free fatty acids which block the pyruvate dehydrogenase enzyme. All of these will increase lactate level and causing lactic acidosis. Multiple drugs and toxins may cause lactic acidosis. Most of them, the main pathophysiology is by preventing mitochondrial metabolism of pyruvate or block liver metabolism of L-lactate and even conversion of pyruvate to L-lactate. In specific beta-2 agonists, as pheochromocytoma, they increase glycolytic activity and block pyruvate dehydrogenase enzyme. I will concentrate more on metformin. Regarding metformin, what is the basic theoretical mechanism that metformin may cause lactic acidosis? Metformin may block electron transport chain and oxidative phosphorylation. Metformin may cause pyruvate carboxylase enzyme. Metformin may inhibit gluconeogenesis and block the conversion of lactate into pyruvate by the kidney. So all of these will increase lactate level and cause the basic theoretical lactic acidosis with metformin. But actually in the clinical situation, does metformin cause lactic acidosis? There's a large review article in Cochrane comparing 347 trials. They found that there is no evidence of increased lactic acidosis or increased serum lactate in metformin in comparison with other anti-hyperglycemic treatment. And they said that metformin-induced lactic acidosis occurs only in patients with predisposing factor to hypoperfusion and hypoxemia. And many reported cases of lactic acidosis with metformin found to be with high serum metformin level more than 5, and thus therapeutic level of metformin is actually below than 2. And as we all know, our recommendations and suggestion metformin use in renal patients, no contraindication above GFR more than 45. It is contraindicated below 30, and between 30 and 45, it is better not to initiate, and if the patient is already on metformin, we have to close monitoring this patient. The last cause of type B lactic acidosis: inborn errors of metabolism, congenital inherited disorders, whatever the name of the disease. Mainly the pathogenesis is due to deficiency of pyruvate dehydrogenase enzyme, pyruvate carboxylase, abnormality in electron transport chain, or decreased uptake of pyruvate by the mitochondria, or abnormal metabolism of lactate in the liver. We said that we have two types of lactic acidosis, but actually there is interaction between both in many causes of lactic acidosis, as in sepsis. We said that in sepsis there is hypoxemia, and this will cause type A lactic acidosis due to hypoperfusion. But it was found that even after fluid resuscitation for the patient is still in lactic acidosis, And this is explained by decrease of lactate circulation from the circulation by liver and kidney in case of sepsis, causing type B lactic acidosis. It was found that in sepsis, due to inflammatory mediators and markers, there may be pyruvate dehydrogenase enzyme inhibition, and sepsis is a stressful condition, and there will be high level of epinephrine, and it will cause lactic acidosis of type B. Regarding diagnosis of lactic acidosis, I will talk in 3 issues. The first issue that basically lactic acidosis, if it is isolated lactic acidosis, it will be presented by high anion gap acidosis, but actually it may be presented by multiple forms of acid-base disturbance rather than metabolic acidosis. This is due to the coexistence of other conditions with lactic acidosis, so the patient may be acidotic, may be alkalotic, may be of mixed disorder, even in the presence of lactic acidosis. The second issue regarding lactic acidosis diagnosis is the lactate sampling. It is important to prevent glycolysis in the test tube itself in vitro, especially if the patient has leukocytosis and high hematocrit. This may increase the level of metabolism of the cells in the test tube, elevate the lactate level, and give normal value of abnormal high lactate serum level. So it is important to make the maximum turnaround time of the test tube about 15 minutes, or storage of the sample on ice, or using fluoride in the test tube to prevent in vitro glycolysis of mainly the red blood cells. The third issue in the lactate or lactic acidosis diagnosis is that in some cases with ethylene glycol poisoning, there may be false elevation of blood lactate. This is because glycolate, which is a metabolite of ethylene glycol, biochemically, it looks like the lactate molecule itself. So, as they structurally similar to each other, a number of analytical devices cannot distinguish between both and give falsely high elevated lactate level, although the patient had no lactic acidosis. Regarding the relation of lactic acidosis and its relation to prognosis, L-lactate can be used. It is a useful tool for screening risk stratification and prognosis, especially in critically ill patients. This study shows that with high serum lactate level in critically ill patients, there is increased incidence of mortality within different ranges of serum lactate, even within normal serum lactate level. And it is suggested that all patients with a lactated admission above 2.5 should be closely monitoring for signs of deterioration. Even patients with lower lactate level should be considered for serial lactate monitoring for possibility of elevation. What is the ideal treatment for patients with lactic acidosis? The cornerstone part of the management is to treat the causative factor or the causative disease or the cause of the disorder, because lactic acidosis is not in itself as a diagnosis, it is a part of a systemic disease. The second point, what about using of serum sodium, what about the use of sodium bicarbonate? What is the role of sodium bicarbonate in management of acidosis due to lactic acidosis or due to acidosis in general? It was found that using sodium bicarbonate in general in the body, especially in high doses, has negative effects. It may cause vasodilatation by different mechanisms, decreased cardiac output, decreased PO2, or causing intracellular acidosis. So theoretically, sodium bicarbonate, especially in large doses, has negative effects on the body. This is a summary of all trials that tried the use of sodium bicarbonate in patients with lactic acidosis. In summary, all trials found that sodium bicarbonate administration failed to improve hemodynamic status of the patients. Even in a recent trial, the use of serum of sodium bicarbonate in patients with metabolic acidosis increased all-cause mortality and risk of hypocalcemia. So when to use sodium bicarbonate in cases of lactic acidosis or in acidosis in general? It is better to use bicarbonate only in patients with severe acidosis, with pH below than 7.1 or below 7.2, the patient is cardiac, or if there is hemodynamic instability. And it is recommended to calculate the bicarbonate dose or about only 50% of the body weight at first. And it is important to administer sodium bicarbonate in a slow rate. And it is important to monitor the serum calcium and start to give calcium IV if there is possibility of hypocalcemia. And finally, we may consider dialysis if there is no response to the medical management of acidosis. And finally, the second least uncommon type of lactic acidosis is the D-lactic acidosis. It is commonly happen in patients with short or bypass small intestine, short bowel syndrome. There is increased glucose fermentation in the colon due to overgrowth of acidic-resistant gram-positive anaerobe, especially lactobacillus, which will cause lactic acidosis, D-lactate, and the D-lactic acidosis. D-lactate is formed in high amount, absorbed to the stomach circulation. It causes ataxia and central manifestations due to D-lactic acidosis. Finally, my home messages. Measuring L-lactate and detection of L-lactic acidosis may be a key for diagnosis of a hidden disorder. Most cases of metformin-induced lactic acidosis occur in patients with conditions that predispose them to hypoperfusion or hypoxemia. There is an overlap between different types of lactic acidosis, as in sepsis, overlap between type A and type B. Coexistence of other conditions may affect acid-base balance and results, so lactic acidosis may not present by pure high or wide anion gap lactic acidosis. Lactate sampling needs special precautions to avoid more production of lactate in the test tube. L-lactate level is related to mortality in critically ill patients even in the normal L-lactate level. Treatment of L-lactic acidosis must be targeted toward the original cause of the disease. Using bicarbonate has no role in management of L-lactic acidosis except in cases of severe acidosis, and thank you.